I'm very honored to have Dr. Eugene Shostak, who is an interventional pulmonologist at Astera Cancer Care and New York Presbyterian Hospital, Weill Cornell Medical Center. Dr. Shostak is an assistant professor of medicine in cardiothoracic surgery who specializes in interventional pulmonology. Dr. Shostak specializes in advanced diagnostic and therapeutic procedures for patients with lung cancer or other thoracic disorders. We are very honored to welcome Dr. Eugene Shostak and appreciate him taking time to educate you all this evening. I would ask everyone to please enter your questions in the chat box as we go through the presentation, and then I will read each one at the end and the doctor will answer. And now I am very honored to present Dr. Eugene Shostak. Welcome, Doctor.
Hi, thank you very much, Karen, and thank you for the opportunity to join this evening and to speak to members of the community about some of the topics that I think are quite relevant for the pulmonary community. We are going to go through several key topics, which includes diagnoses such as asthma, COPD, which is chronic obstructive pulmonary disease, a couple of slides on smoking cessation, and some updates and information on lung cancer screening, as well as some of the procedures that we perform for patients who have various types of pulmonary conditions. So we'll start by talking about asthma, which is a very common condition that many of you are familiar with. Asthma is a chronic disease of small airways that can present with wheezing, chest tightness, breathlessness, and usually the symptoms get better with an inhaler. To get into asthma a little bit more, this is a good schematic that shows you side-by-side comparison of normal airway caliber versus what happens in asthma. And as you could see on the right hand of the screen, the lumen of the bronchial is filled with mucus, inflammation, secretions, etc. And so this is what causes airflow obstruction and wheezing. 60 to 70% of asthma could be allergy mediated or otherwise environmental. And you could think of it as an abnormal response, inflammatory response to some type of a trigger. Again, trigger could be anything in the environment, trees, pollen, dust, animals, etc. So this is a fairly long list of all the different asthma triggers, and every patient usually will know what precipitates their asthma so that they can avoid it. But obviously certain weather patterns such as cold weather is a common precipitant. That's why asthma gets worse in the wintertime, gets better in the summer. The prevalence of asthma is quite high. So 25 million of Americans are diagnosed with asthma. 1 out of 10 children may have asthma. Some of the financial implications are here. $80 billion annual cost. Over 3,000 people die of asthma each year, et cetera, et cetera. What's interesting is that 71% of asthmatics misuse their inhaler, or they don't use the inhaler correctly. And that also contributes to poor asthma control. One of the things that we tell patients is to develop an asthma care plan, which is to get a good sense of when asthma is starting to get worse, and when should you take a rescue inhaler, when should you go to the ER, etc. And this device may be familiar to some of you. It's called a peak flow meter, and basically you blow into it, and it measures your peak flow, how much air you can exhale, and then you can set these little bars to demarcate green, yellow, and red zones. And so if you're in the yellow zone, you have instructions here. If you're in the red zone, you go into the ER. If you're in the green zone, you're okay. So it's good to develop this and sort of gauge symptoms at home. So there are some non-pharmacological management options. Obviously, we talked about avoidance of triggers, which is a big one. Not smoking, various types of diets, perhaps. But, most of the asthma is treated pharmacologically. So these are the different types of delivery devices. Metered-dose inhaler, MDI, is a device, as you can see here, where you basically press on the canister, and as you press, you take a deep breath in. We have nebulizers, which are very helpful. So a nebulizer machine essentially is a liquid preparation that you pour into a little well, and then the machine turns it into vapor, and you breathe it in. So the main difference between a nebulizer and a metered-dose inhaler is that, number one, nebulizer is not portable. Number two, it's great for those who either cannot coordinate the use of a metered-dose inhaler, children, for example, or patients who have severe lung disease and they simply cannot take, or they cannot generate enough inspiratory force to get the medications into the lungs. So this is one of the common suggestions that we usually have for patients with severe lung disease, is to switch from an inhaler to a nebulizer. This is a slide that basically gives you a sense of a step-up model where we are able to increase or change various medications in order to improve symptoms of asthma. So depending on how bad the symptoms of asthma are, you may be offered various combination inhalers. There are medications that have two in them. There are triple medications inside a single inhaler. And so it is sort of done in this sort of fashion. This is a very busy slide, but I like the slide because first of all, it shows you how many medications or inhaled medications there are out there. It also breaks it down by various categories. So the top is it's called short-acting beta agonist. So that's albuterol, which is sort of your quick rescue inhaler. And then the second line are the corticosteroids. Those are inhaled steroids, which are very commonly used in asthma. And then the third line is another group of medications. And then on the bottom, you have combined medications. So they take 2 or 3 medications from different classes and put them together. And then at the very bottom, we'll talk a little bit about biologics. Biologics are extremely potent. They're very, very powerful medications for patients with allergic asthma. And they've been out now for several years, and they've made a tremendous impact in quality, in the improvement of symptoms and quality of life improvement in patients with severe asthma. And there's also a procedure that sometimes gets performed. That's on the bottom here, bronchial thermoplasty. We'll talk about that as well. So as you remember, we just said that 71% of asthmatics do not use the inhaler correctly. So again, you may hear this from your doctor, or you probably can also find this online. But essentially, if you are going to use an inhaler, the first thing you want to do is you want to breathe all the way out. You want to shake the inhaler, make sure it's working, make sure it's full. Then when you put it in your mouth and simultaneously you press down and you take a deep breath in. Then you need to hold your breath for 10 seconds, which is the part that many people forget. And then you exhale. So this way, you're guaranteed to get the medications delivered. Again, as we said before, in the last couple of years, there have been various new biological agents that have been developed mainly for allergic asthma. These are injectable medications that are administered either every 2 weeks, or sometimes every 4 weeks. And again, this is approved for allergic asthma. It's extremely effective. So something that I do in my area of work is a bronchoscopy procedure for asthma. And again, this is for, for select 5% out there, or maybe 10% at most of asthmatics. And again, your doctor will be the one to tell you about this. But essentially, there is a group of patients who have poorly controlled asthma despite interventions that we talked about and various types of medications. And what we're able to do is we're able to go down with the camera and apply energy, deliver energy using a small catheter to essentially decrease the thickness of the muscle that is essentially causing a narrowing of the bronchial tubes. So if you think about your other muscles in the body, when you go to the gym and you exercise and you build up your biceps and your triceps, well, there are smooth muscles in your bronchioles, right? And these muscles contract like any other muscle in the body. So when an asthma attack happens, the muscle will contract and it'll cause a spasm and a constriction. And so the more times the muscle contracts, the more thick it gets. It's almost like exercising. And that's what causes the narrowing of the passageway. And that's what the procedure aims to address. So I'll show you a little video of a camera and this small catheter that we passed. And the sound is the sound of the energy that's being delivered. And we are able to treat various parts of the lung using this type of device. So we'll switch from asthma to something called COPD. Again, COPD, chronic obstructive pulmonary disease, comes in two different flavors, so to speak. There are those who have chronic bronchitis, so they're constantly producing a lot of phlegm, usually in the morning. And then there are emphysema patients who usually don't have a lot of phlegm, but what they have is they have destruction of the lung tissue. So on a CAT scan, these two will look very different. One is a lot of phlegm, but not much destruction of the lung. The other one is destruction of the air sacs in the lung. Both of them are heavily associated with smoking. It's the most common cigarette-associated lung disease. And sometimes it's not very clear what's asthma, what's COPD. Sometimes there's an overlap, but conceptually, we like to separate them out into two different groups where asthma tends to start in childhood. We talked about environmental and allergic exposures. Inhalers do help. And again, most cases are well controlled with medications. COPD is typically older people, smoking-related lung disease. When we do a breathing test, a pulmonary function test to measure the lung function, we can usually tell which one is asthma, which one is COPD. And again, because these are older people and it's smoking-related lung disease, there is a higher association with other organs, such as heart failure, elevated carbon dioxide levels, et cetera, et cetera. So these are typically sicker people. Again, like we said before, there are some non-pharmacological approaches. I threw this in just for completion's sake. I think the one that you often will hear about is this breathing exercise, pursed sleep breathing, that often, if you are someone who has advanced COPD, you may be sent to a pulmonary rehab where they can teach different breathing exercises and muscle strengthening exercises, and this is a big one. Other types of breathing, other types of breathing exercises called abdominal breathing can also be helpful. But again, we're kind of coming back to this big chart of multiple different inhalers, because that is really what your doctor is going to be is going to be discussing with you. And again, the inhalers are a little bit different, but conceptually, it's the same step-up model that we saw with asthma. And there's some overlap in inhalers as well. So now, just like I showed you before, because I'm procedure-oriented, so I showed you a procedure for asthma. We have a procedure for emphysema. Again, for patients who specifically have a lot of lung destruction. And what we are able to do now, we've been doing this now for the last 2.5 years, is that we're able to put in small valves, small devices into the airway that allow air to exit and not re-enter. So when patient is breathing out, the valve is going to open to allow air to exit. When the patient's breathing in, the valve is going to close. So over time, you will have collapse or deflation of the area of the lung that was treated with valves. And what that serves to do, what that serves to do is that it shuts down the area that's destroyed and hopefully helps the rest of the lung expand. And that's what you see here in this picture, where arrows are pointing to areas that are very destroyed. And there's really not much lung tissue here. And if you're able to sort of collapse that area and allow the rest of the lung to open up, there's going to be improvement in symptoms. This is a short demonstration of a bronchoscopy when we go in with a camera and we deploy these valves, and you could see that the valves are sitting there. There's one valve up there. There's another one that's being deployed. And again, this is something that your pulmonologist may talk to you about. This is something that we do for severe emphysema. You could see the opening and the closing of the valve. So again, poorly controlled asthma and COPD a lot of times has to do with improper use of inhalers, improper technique. But there's other contributors as well. Sinus disease is one of them, because there may be a lot of postnasal drip and mucus that's dripping from the sinuses that lands on your voice box. It's going to make you cough. It may make you get bronchitis. Acid reflux. We think acid, the acid from the stomach can come up, spill over into the lung, make you cough. But by far the most common cause of COPD, as we said before, is smoking. So what can we say about smoking? 25% of American population smokes, quite prevalent, especially in the younger people. Some of the numbers, some of the statistics are up here. What's nice nowadays is that we have many different options for smoking cessation. Most of them are nicotine replacement strategies, of which there are many different types, whether it's a patch, a gum, an inhaler, all three combined, which, by the way, combining different modalities is more potent than separate. And then we have certain medications, Wellbutrin, Chantix, that are also helpful. And of course, group discussions, group therapy, smoking cessation, counseling is very important. I think everything starts from the brain. So in other words, if in my experience, if a patient is ready to quit, then that's the biggest part of the challenge, is for them to say that they're ready to quit. Once they're ready to quit, we can throw a lot of different medications and a lot of different options at them to help them get to the goal. Some patients aren't ready to quit, so then they're not ready. So now, but in the last couple of years, we've heard a lot about e-cigarettes and vaping, especially among younger people. So what does the medical community say about e-cigarettes? Well, so first of all, e-cigarettes this is a nice cartoon that I borrowed from a journal that talks about an e-cigarette, but basically there's a liquid inside the cartilage, and when the device is activated, the liquid is sort of vaporized, and you are inhaling that liquid. So there are various types of various types of substances in that liquid. Most of them are flavored. They have various amount of nicotine. So it is, in a way, a nicotine replacement product. However, the problem with e-cigarettes is that the chemicals in that liquid, which are being inhaled, have been shown to cause various types of lung disease. It could be anything from bronchospasm, what we call reactive airway disease, like asthma, and unfortunately, it could also include much more serious types of inflammatory lung diseases, causing respiratory failure and even death. So this is a report from January of 2020 that talks about over 2,000 patients that were hospitalized with vapor-induced lung injury. This is from all over the country, and 60 deaths that have been attributed across 27 states. So basically, the short answer is that the medical community does not recommend using e-cigarettes in lieu of other methods of smoking cessation because of all these potential problems that you may encounter. So we're going to switch gears away from smoking-related lung disease and talk about lung cancer screening, because again, lung cancer, we know, still remains the biggest killer of American population, and we now know that there are certain people who are smokers who are eligible for lung cancer screening. So it's important to know this and to talk to your doctor if you are in this category. So 50 to 80 years of age, currently smoking, or quit in the past 15 years, and you have 20-pack year smoking history. So 20-pack years means 1 pack a day for 20 years, or half a pack a day for 40 years, right? So it's got to, when you multiply, it has to be 20 or above. So if you are in this category, then your doctor should be talking to you about lung cancer screening. Basically, lung cancer screening involves doing CAT scans once a year to look for any abnormalities, any nodules, any spots, et cetera, et cetera. It's not a simple decision, yes or no. It's a discussion that you typically have with your doctor about the pros and cons. Like any other screening test, there's always the bad, the pros and the cons, and so it's something that should be explored. But we do know from multiple studies that lung cancer screening saves lives, and so it's something that should be considered. So, what do we see as pulmonologists in patients who come to us? Well, we are sort of on the other end of the spectrum, where we have a patient who had a scan and there was an abnormality, and so now, as a pulmonologist, we're looking at the scan and we will make a recommendation about whether a biopsy should be performed or not. And there are different techniques to do a biopsy. Sometimes there could be a needle that gets put in, sometimes a camera can go in. But as an interventional pulmonologist, we use a lot of fancy technology, including something called GPS bronchoscopy. So this is sort of a virtual model that we can then use a specialized GPS catheter. We could use the computer to help us get to a certain area. So there are many ways in which this can be done safely. And even now we use robotic assisted bronchoscopy using this Xbox remote controller, and we can advance instruments, again, very safely to get us a diagnosis. So I want to thank you for your attention. Here is my my contact information. like we said in the beginning, I have sort of two affiliations, and the hospital that I'm affiliated with it is New York Presbyterian Hospital in the city, but I also see patients in Jersey, so I would be happy to take any questions. And again, thank you for your time and your attention.
Thank you, Doctor. It looks like we have one question so far in the chat, and I welcome anybody to please enter any questions you have for the doctor. The first question, Dr. Shostak, is there any recommendation for lung cancer screening for a non-smoker who has family members who also didn't smoke, who were diagnosed with lung cancer?
That's a very good question. I'm glad you brought it up. The short answer is no. There is no recommendation right now to screen those patients. That being said, we all recognize that the current screening recommendations are not perfect, and they do not account for patients who have genetic predisposition for cancer, and we are seeing more and more of those patients, especially across certain ethnic groups. So it is not a perfect science, but unfortunately, officially there is no recommendation for that. Now, screening means that you order a CAT scan on someone who has no symptoms and someone who does not require a scan other than for screening purposes. That's what screening means. So there are sometimes patients who we see who have other reasons to get a scan. And so they may want to get a scan anyway for screening purposes. They may not qualify for a screening scan, but they may qualify for a scan for other reasons. And so that's something that you want to talk to your doctor about. But that's a good question.
Okay. And are there any other questions for the doctor? Please take a moment and feel free to type them into the chat box.
We have another question: how to determine COPD? What kind of examination should be done? So COPD, much like asthma, gets diagnosed based on, number one, pulmonary function test. So that's when you go into well, there's different ways to conduct it, but that's basically when you breathe into a tube and they measure your lung volumes. Number two, it's also a clinical diagnosis, which means that we can diagnose it based on imaging and clinical symptoms. So we have other questions here. I have asthma, but only use my inhaler when needed instead of daily. Could this strain my airway? Yeah, I mean, it's not, there's no such thing as straining your airway, but the frequency with which you use the inhaler is something that you should discuss with your provider, because there's different inhalers and they get used differently.
And someone has a question about your name and contact information, and I see that is on the last slide.
Yep. So I'll leave the slide up, and I should have put my name on the slide as well, but it's on the first slide. So it's Eugene and last name Shostak, Shostak.
And actually, I'm going to type in my information here. I'm Karen Parry, Manager of Information Services at the library. Please email me if you would like a copy of the slides. And Doctor, may I ask you kindly to send Dorothy a copy of your slides so I can share them, because oftentimes people like to read them on their own.
Absolutely. Yep. Actually, I think I already emailed them to you.
Okay. Actually, you're right. I do have them. Okay.
So,
and that looks like.
So there's a question: routine X-rays used to be done to screen for lung cancer. Is this done anymore? That's a good question. So you're right. X-rays and sputum cytology were the old way of screening for lung cancer. So that has been replaced. With low-dose CT. So we no longer do X-rays. But that's a good question. Low-dose CT scans is the current way with which we screen.
Okay. Any more questions for the doctor? No? Then I guess we can end here, and I'd like to thank Dr. Shostak for his time. I know he's very busy, and for appreciating the important role that libraries play in health literacy and in helping everyone to be educated and make their best decisions to achieve their best health. So I wish you all a good evening, and thank you, doctor, for your time.
Thank you.
And again, please email me, and I have a copy of the doctor's slides, and I'll send the slides off to you. Okay, thank you, everyone.
Thank you, everyone. Have a good night.